Hello and welcome. My name is Yanshi Wilson, guest correspondent here with MedEdge MEA at the Critical Care Congress in Abu Dhabi. I have here with me Dr. Fuat Saner, who is a specialist in critical care medicine as well as liver transplantation.
I'm fine, thank you. I have to ask you, Ms. Wilson. You have a very interesting name as Wilson. So, how could you have this patient is a Wilson disease, is a copper storage issue there, and it leads also to the transplantation as well. So it's I memorize this name very, very well. For me, it's very well. Yeah, yeah, of course.
So you just got off the stage talking about your specialty in critical care. Can you tell us just a little bit about that?
So the issue is today my talks deals with one was liver cyst device in a failing graft. It means failing graft means if you make a liver transplantation and the graft has a problem beside the, let's say, the functional problems there, and they give a talk about how we can improve this graft function. And beside the standard medical treatments, we have some issues with the, let's say, liver cyst devices like plasmapheresis, MARS. How we can improve the graft function afterwards, and this was the focus of my talk, and the results of that, or my conclusion was that if you have if you have a failing graft, we should do something with liver assist devices in order to improve the function of the graft and save the patients.
Okay. Tell us about an advancement that maybe you're really excited or intrigued about regarding critical medicine and care.
So I think it's not an issue for about what is developed in the critical care medicine. To my opinion, the critical care medicine should be also specialized like the, let's say, primary teams like in internal medicine or in surgery, where you have a gastroenterology, nephrology, endocrine, also have a liver transplant surgeon or the hepatobiliary surgeon or upper GI, lower GI. So what has happened now actually, it looks like that it's expected that every ICU physician should cover every patient. It's not possible. If you're specialized for liver transplant or for hepatobiliary surgery, you cannot cover with the same expertise also patient with a cardiac surgery. So this should be improved and should be better, and then they can have a better outcome with those patients. Moreover, your knowledge about critical care medicine should not only cover critical care medicine with the fluid management, septic issues, or kidney failure, should also cover the primary teams like the indication for the operation or like something the treatment for like hepatologist. And then you can combine your knowledge about it and you can improve the outcome because of discussion with the other teams interdisciplinary on the same level of your eyes.
So essentially, the primary care teams need to have a stronger multidisciplinary approach when it comes to this.
I think they have it already, but I think the critical care medicine have to be more specialized and come when it comes to the approach with the multidisciplinary teams, and this should be done from our side. And I encourage this to have some subcommittees or some subspecialization in critical care. That one group works, let's say, for gastroenterology plus liver transplantation, the other one more for cardiac and cardiology, and then we have a better outcome for this patient. Instead, we have a general ICU people who rotate every week to another place and take care of this patient there. There's no maintenance then.
Okay, so less technology, more on the personnel approach and internalizing the teams to make sure that they all have the better experience from the critical care perspective.
Yes, I support this very well. Yes, of course.
Okay. So regarding liver transportation and things of that nature, what are some things that you feel that can be improved within this particular field?
So it could be improved in that way that we have what is done in the recent, or let me say, what has happened in the recent 20 years. When the liver transplantation starts in 1960, they tried to figure out which patient could be transplanted there. Now almost 20 years ago, it was a contraindication to transplant patient with a cancer. But now we are at a stage we transplant also patients with a cancer, particularly metastatic colon cancer. So there's a huge advancement in space, and we have to extend, the problem is that we have a shortage of organs. So what we have here in the Middle East, or let's say Islamic countries, also like Turkey or like in Saudi Arabia, we have a huge potential of a living donor patients there. So living donor means a healthy guy comes and voluntary donates his right or left lobe to someone else, so most likely to one of the relatives there, and this patient can be saved. However, we have also to work on the disease donor programs, particularly in this part of the world where we have a very lack we have a shortage of disease donor transplants, and we will have to work on this way there. And needs, let's say, a support from the government, and they have to be supported that we have more also disease donors to increase the number of transplants.
I see. So, what are some of your final thoughts that you want to really leave people with before we close here today?
I think the most important is I said already, if the critical care people have to be specialized themselves. Regarding the liver transplantation, there should be closer work together, critical care physicians, hepatology, and surgeons. That not the surgeon hepatologists see you just only as a service subject. They should include you also for put the indication for patients, because we are taking care of the patient before and after the transplant when they are in the ICU. And the third one is probably in voting for and more recruiting disease donors also in these countries there, like in the Middle East, to increase the number of patients, because still we have patients who are dying from liver cirrhosis, which then can be saved with the appropriate liver organ donor.
See, well, thank you so much, Dr. Saner. I really appreciate your time.
Thank you so much for your interview.